Welcome to the Bridges Center seminar. Thank you for taking the time out of your day to learn more about weight loss surgery. Over the next 45 minutes, we will provide you with a general overview of the program, including some of the team members you'll meet along the way, and we'll talk about the different educational and support offerings. So, sit back, get comfortable, and enjoy. You may be watching this video because you know someone like Michelle. Michelle lost 134 pounds with weight loss surgery, which helped her drop 11 clothes sizes and improve her overall health. Or maybe you know someone like Amy. Amy lost 123 pounds with weight loss surgery, which helped her reclaim her energy and her figure. Monica has a great smile. She lost 98 pounds with weight loss surgery, which helped her boost her self-esteem and overall health. We also have many men involved in our program. Charles lost 248 pounds with surgery, which lowered his risk for diabetes and heart disease. Christy lost 121 pounds over her 12-month journey and was able to take control of her life. You're probably wondering how long from today until you're one of our testimonials. We're going to go over the different steps in the Bridges journey. Then, you will meet with your physicians who will address the different surgery options. We'll provide you with some tips for success, and then we'll talk a little bit about what your experience will look like 5 years after your surgery. The Bridges Center is a program designed to help patients not only lose weight, but to keep it off long term. We are a center of excellence facility, which shows our great patient safety, advocacy, and commitment to your long-term success. We are recognized as a top-performing center, and we also have a very comprehensive data tracking system to prove our patients' results and safety. The Bridges Center provides quality education. All our education classes are free and are part of your program experience. The first step is the seminar you're watching today. We offer a monthly post-operative class and a support group. We are also committed to a 5-year follow-up program, and we ask that you are committed to the same time frame. At the Bridges Center, the surgeons are a big part of the weight loss surgery process. They are board-certified surgeons specializing in bariatric surgery. We also have a board-certified physician's assistant who specializes in post-op bariatric surgery and follow-up care. You work with a psychologist, not only in the beginning of your journey, but also in our support group for long-term success and guidance. We have a registered nurse, a licensed practical nurse, a follow-up care specialist, and most importantly, patient advocates who will walk you through the whole insurance process. The surgeons will help you determine what surgery is the best option for you, so you can have a healthy, long-term weight loss for life. The Bridges Center will help manage your insurance requirements, get you ready for surgery with education and support, and help you stay on track with your weight loss post-operatively. We're here to help you through your journey, so please feel free to call us with any questions you may have. Getting started. Let's talk about a few things to get you started on your journey to weight loss. The Bridges Center has a bariatric education and support program. You'll be working with your patient advocate to make sure you get the appropriate preoperative and postoperative education, as well as be aware of our support groups that are available to you long term. Education and support are important, but not only for weight loss, but for weight management. It may be beneficial for you to bring your support person with you if they're available. The Bridges Center program provides education and support from skilled and experienced healthcare professionals on our team. The weight loss surgery is performed by a surgeon experienced in not only surgery, but in helping you choose the surgery that is best based on your personal health history and long-term goals. The Bridges Center bariatric education classes include 101 classes, which are an introduction to weight loss management and surgery you will receive. 201 classes will prepare you for surgery, including what to expect during your hospital stay, along with preoperative and postoperative dietary instructions. Our 301 classes are available for patients post-surgery, and this will offer long-term bariatric lifestyle education, and support. Now I'd like to introduce you to Dr. Juarez. He will give you an overall view of the bariatric surgery experience and answer many of the questions you may have about your weight loss journey.
I'm Dr. Juarez. I'm one of two bariatric surgeons at St. Luke's Hospital that does the weight loss surgery. I've been doing it for approximately 12 years, and today we're going to talk about obesity, how it affects you, and the 4 procedures that we perform. First of all, the first slide shows that 64% of America is overweight. That means patients are on average 30 pounds over where their ideal body weight should be. But the 10 million you see there are the people that we actually perform the surgery or are candidates for surgery. Now, what is BMI? BMI is the body mass index, and it's calculated by the patient's weight divided by their height in the metric system. When a patient gets to be 100 pounds overweight, that's when the BMI is equivalent to 40. And patients become eligible for surgery at a BMI of 35 with comorbidities. Now, what is a comorbidity? A comorbidity is an illness that's affected by patient's weight. And here you can see on this slide that there are at least 20, but there's probably a lot more. And also patients who are overweight also have a higher incidence of cancers. In this slide, it's showing you that there are certain complications of being overweight. There are the medical problems, which are the comorbidities I talked about. There are orthopedic problems. Patients are overweight. They can't fit into certain seats, airplanes, and things like that. There's a lot of psychological problems associated with it, and there are a lot of cost associated with being overweight. For instance, a diabetic patient will need medications. At some point, he may need dialysis because of kidney failure, or need a coronary artery bypass because of the atherosclerosis, and all that costs a lot of money. In this slide, it's just explaining that obesity is complex, chronic disease. It used to be thought that the fat cell was a benign cell, that it didn't do anything. Well, what it actually does, it causes an inflammatory state throughout the body, and therefore you end up developing such things as hypertension, diabetes, and heart disease. Now, we're also going to talk about what types of procedures we perform. Now, these procedures are meant for patients who've already done the diet, the exercise, all the things that patients normally go through. But in the end, when patients cannot lose weight and are affected by their comorbidities, then become eligible for weight loss surgery. And these are the 4 different types of surgeries that are performed here. First is the gastric banding, next is the gastric bypass, then the vertical sleeve gastrectomy, and the biliopancreatic diversion or duodenal switch. I will get into all these and explain how they're performed and also the potential risk and complications. So understanding the surgical options, each procedure has its goals. Different procedures are meant for different weights and different ages. When you end up in our office, that's when we explain to you which procedure is the best one for you. Now, these are just statistics that we have come up with, and that not only at our center, there are many centers of excellence throughout the country in different states, and so we all get data from each other and present these, and these are the averages of the weight loss. In the gastric band, it averages about 30% weight loss, and it takes usually 2 years to get there. Vertical sleeve is about 60% in 1 year. The bypass is about 70-75%. And the duodenal switch is the best at 80% weight loss at 1 year. Now, what is the criteria that we use for qualifying patients? This slide is a general criteria that we use today. You must be between 18 and 70 years of age. We don't do minors because it's hard to say if the minors really understand what's going to happen. And then after 70, the benefit of the surgery versus the terms of how long patients are going to be around is not that great of a benefit, so we do not perform it after that. Now, as I said before, the body mass index must be around 40, but if you're at 35 with a comorbidity such as diabetes, hypertension, or sleep apnea, then you can qualify. Patients also have to have some sort of documentation of the things that they've tried and what they've failed at. And you have to commit to the lifestyle changes, and this is long-term. And we say this because if patients don't commit to the diet and exercise, and many patients can gain their weight back. These are the contraindications to surgery, and this is why we wouldn't perform surgery. Obviously, if the patient is pregnant, patient does not have a good heart to sustain the surgery, or good lungs, clotting disorders, psychological issues that are not corrected, metabolic issues, liver disease or like cirrhosis, substance abuse, and smoking. So let's get down to the actual procedures and then determine which one is best for you. The lap banding is the first one we'll talk about, and this is a procedure that has been around since 2001, but it's been around a lot longer in Europe. They were doing these 20 years prior to when we started, and this is the diagram of the actual band being placed on the upper part of the stomach. What it's supposed to do is it's supposed to limit the amount of food that you consume at that particular time. And then you see the tubing connecting to the port. And the port is also placed underneath the skin, and it can be placed anywhere in the abdomen. But what it does is that if once you get your band in, approximately 6 weeks later, a fill is placed into that port, and it fills up the balloon that's around the upper part of the stomach. And the fills can be done anywhere from 3 to 4 times during the year. We start these patients on a clear liquid diet approximately 2 weeks before surgery, and also 2 to 3 weeks after surgery. And the reason we're trying to get patients accustomed to taking liquids. We encourage exercise. The patients will be seen again in the office in approximately 2 weeks post-op, and then periodically throughout that first year. Now, the banding is what we consider a restrictive procedure. That means we're restricting the amount of food that you consume at that time that you're actually eating. It is not a malabsorptive procedure, and this is why its performance isn't as good as the other procedures. And this slide is showing you the potential complications of the banding. The first you see there is gastric perforation, which is not real common. Perforation means there's a tear in the area where the band is located, and that's up in the upper part of the stomach. Now, those tears can occur right away, or they can occur years down the road because the material that the band is made of is like a plastic, so it can erode and eat away at the lining and actually end up inside the stomach. Again, 3% lifetime, so it's not very common. Slippage is when patients vomit excessively and they change the orientation of the band, and then it can cause heartburn or obstruction. And that perhaps is one of the more common things, and it's about 10% of the patients. The most common problem that patients have with the banding is the heartburn, there at the very bottom. The tighter we make the band, the more heartburn patients will have. And as many as 60% of the patients can develop heartburn to the point that the fill has to be taken out, and we will see improvement of symptoms. The next procedure is what we call the gastric bypass, or the Roux-en-Y gastric bypass. It's known by those two names. This is a malabsorptive procedure. That means that it's working in two ways, and this is the diagram. As you can see, we've created a small pouch from the upper part of the stomach, and its volume is about 30 cc's, or maybe the size of an egg or golf ball. And that's the amount of food that you will be able to consume at that timed setting. Now, the intestinal part is what we call the malabsorptive part, and that's the part where the food normally would have gone through and all your nutrients would have been absorbed, but because of the change, your nutrients and calories are going to be decreased. For an example is if you were sat down and ate a 2,000 calorie meal, you may only absorb 1,000. And so this is why you have such rapid weight loss with this operation. It is the most common surgical procedure done today, and its performance is about 75% weight loss in 1 year. With this one, again, you get a 2-week preoperative diet. The reason we do that is so that the intra-abdominal fat decreases, and the liver also will decrease as much as 25% by volume. So that allows us to perform the surgery much easier laparoscopically. We also continue the patients on the liquid diet for 2 weeks. We recommend exercise. Some of the medications will be discontinued or lessened as you preoperatively as well as after surgery. And we see patients 2 weeks post-op, and we'll see them again at 6 to 8 weeks, then again at 6 months, and then a year. Labs will be done usually in the first 3 months to make sure that the electrolytes are still within normal, and then there will be continued support groups and education classes, which we encourage the patients to continue. Now, this is a very important slide for those who are considering weight loss surgery. These are the complications, the main complications that we worry with this particular surgery. The number one potential problem is the leak. And the leak is when you get disruption of the hookup on the upper anastomosis or the lower anastomosis. Fortunately, our leak rate here is about 0.5%, so it's not high, because leaks can lead to severe complications and can lead to death. So very important to know about that. The stricture is the opposite of a leak. Over time, the patients can develop ulcers and narrowing of the opening. So these patients will experience nausea, vomiting, and pain. The other things that can happen immediately are bleeding, blood clots, pulmonary emboli. Long-term are going to be ulcers, nutrition, anemias. Some patients will experience diarrhea or constipation, and perhaps a dumping syndrome. The next operation is the most complex operation that is performed. About 5% of the surgeries are what we consider the duodenal switch. It's performed less because these operations are recommended for patients who are super morbid obese, or those patients that are in the 400, 500, 600 pound range, because it's hard to get those patients to a lower weight with the other surgeries, and this is the most effective surgery that is available. This next slide is a diagram of that surgery, and so as you can see, it's quite complex. It can be performed laparoscopically or open, and the difference with the gastric bypass is that the connection is not on the upper part of the stomach. The connection to the intestine is in what we call a duodenum, or the first part of the intestine. What makes it very a malabsorptive procedure or nutritional operation is the fact that the other connection at the bottom, where you see the common channel, the percentage of the intestine, there's about 20% of the entire intestine. The intestine normally is about anywhere from 10 to 15 feet, and the common channel is going to only be about 2 to 3 feet in length, and so that's the only part of the intestine that you have to absorb all your nutrients. And so these patients will be malabsorbing not only the carbs and fats and sugars, protein, but also all the vitamins like A, D, E, and K. And so it's very, very important with this operation that patients continue with their replacement of vitamins and calcium and eat a high-protein diet. The potential complications are described on this slide. One of the main things, you have now 2 different areas where that can occur. You have the vitamin deficiencies. These patients are more prone to diarrhea and excess gas, as many as 5 to 10 a day. And so patients have to be informed of this to make sure that there are lifestyle changes that they need to make in order to compensate for this. Patients can develop reflux, and they can also have excess weight loss. The next operation is the gastric sleeve. That's the other one that we perform. Look at the diagram of this. This is the first part of the duodenal switch. And this operation came about because some of the patients that were in the 600 pound range have a high risk of dying with that surgery, as high as 8%. And that alone is because of the excessive weight that these patients come in with. So this operation was performed on those individuals to reduce their morbidity and mortality. And so now it's become a separate operation on its own because it's got good weight loss. Again, this patients will lose about 60% of their excess weight in 1 year. It's actually a very simple operation to perform. It's performed laparoscopically. We do remove that part of the stomach, about 80% of it. We put in a tube that kind of measures how big the size of that stomach that's going to be left. This is permanent and is not reversible. Its complications are a leak along the staple line or bleeding along that line. Patients can get nausea or strictures with this, but it's an easy operation to perform, but it's also a very easy operation for the patients to tolerate versus the other ones. On this slide, we're talking about the different potential complications with any surgery, any weight loss surgery: pneumonia, heart attacks, hernias, nausea, vomiting, gallstones. And perhaps what's also important for patients to know is that look at the death rate. The death rate is quite low when you compare it to open heart bypass surgery. The death rate for band patients, like one patient in 2000 can die. With the sleeve, it's probably less than 0.5%. With the bypass, it's 0.5 to 1%, and with the duodenal switch, it's the same. So very important to remember that. This slide again is now just commenting on other issues with patients who are overweight. What do we do with patients who have a hiatal hernia? Hiatal hernia is when the upper part of the stomach, where it comes to the chest, there's a bigger opening that's normal. Well, if this is present, we will repair it. Hair loss patients, most patients will have hair loss not only because of the stress of the surgery, anesthetics, but also because of the protein malabsorption, and that will be greater in the patients who have had a duodenal switch or a gastric bypass. Now, what do we do with all that skin that's left over on some of these patients? We refer these patients to our favorite plastic surgeons, and sometimes we will perform the panniculectomy on our own patients.
Now I'll introduce you to Dr. Fang. He will go into more detail about important information you should know before going into surgery.
As far as other potential complications from any type of bariatric surgery, anyone who undergoes any sort of surgery that involves general anesthesia, there are risks for things like pneumonia, heart attack, stroke, bleeding, infection, those types of things. But there are some specialized things that we really want patients to be aware of. If you have abdominal pain that's out of proportion to what we would normally expect from recovery from surgery, if you have any type of nausea or vomiting that doesn't appear to be related to overeating or eating the wrong types of foods, we really need to know about it, because some of these complications are very specific and specialized to bariatric surgery. And we've had patients who've come to other hospitals, even had CT scans. A couple of patients a couple of years ago actually had surgery done where other surgeons weren't able to identify what the problem was, and they still had the same symptoms after the surgery. They came to see us, and we had to reoperate on them to treat, types of intestinal obstruction or internal hernias or things like that that are not normally identified. Blood clots are probably the number one cause for death after surgery that involves general anesthesia. So that's really why we do all sorts of different things to really reduce your risk of blood clots. We give patients injections of heparin before and after surgery to prevent their blood from clotting as quickly. We put compressive hose on patients' legs. And then probably most importantly, we make patients get out of bed and walk, because the main risk factor for blood clots in legs that can lead to pulmonary embolism is prolonged inactivity or prolonged bed rest. So it may seem kind of cruel, but after surgery, your nurse is going to come by, she's going to kick you out of bed and make you walk in the halls. That's really, life-saving. As far as other potential complications, failure to lose weight, this is very unusual. The only patients who we really see who really haven't lost much weight may be band patients. The one drawback to the band surgery isn't just that its weight loss is less, but also that its weight loss is a lot less predictable. For every patient you see out there who's lost 100 or more pounds, or someone else out there who's lost only 20, 30 pounds and can't lose any additional weight. The bigger problem is really weight regain in the future. And with any of these operations, if patients don't stick with the permanent behavioral changes, the eating habit changes, they can gain weight back in the future. So that's where we really encourage patients to continue to follow up with us, to continue attending support groups to stay on track to maintain the weight loss, because we want these patients to really realize their maximal amount of weight loss and really to maintain this weight loss permanently. The last thing here is death. People always wonder, what's the risk of death from these operations? And it's less than 0.1%. That's actually very low. If you compare it to an operation like gallbladder surgery that we do very frequently these days, the risk of death from gallbladder surgery is 0.5%. And you wonder why a simpler operation like gallbladder surgery is more risky than bariatric surgery, which is more complex, and you're performing it on a higher risk category. And the main reason is because of all the preparation that's done in preparations for surgery. We want to make sure that patients are prepared for this surgery. We want to make sure you're in the best shape possible for this surgery itself. As far as some additional issues are not always related to the surgery itself, but related to comorbidities. So one thing that's very important when we do see patients in the office is we try to get them to lose weight in preparation for surgery. We will put patients on a low glycemic index diet. In the last 2 weeks before surgery, we actually have patients start on a liquid protein diet that's very low in carbohydrates to shrink their liver down. One thing you don't want to do if you know that you're approaching surgery is to go out and go to all your favorite restaurants because you're afraid that you're never going to be able to eat there again. Because if you come in and you're 25, 30 pounds heavier, that makes surgery much more difficult to do. And if we do see this, then we actually will cancel or postpone the surgery and get you to lose that weight before we'll actually reschedule the surgery. A hiatal hernia is a hernia where your stomach slides up through the diaphragm into the chest. It's not a hernia that you can feel. Hiatal hernias are usually associated with reflux or heartburn. And when we do these surgeries, because we're working in the upper abdomen there, if you do have a hiatal hernia, we'll usually repair it at the same time. If you are interested in gastric banding surgery and you have a large hiatal hernia, then the gastric band is probably not a very good idea because the band will actually fit over the stomach, which is involved with the hiatal hernia. So the anatomy is not very normal, and your results are usually not as good as someone who does not have a hiatal hernia. Hair loss. A lot of people have heard that you will lose hair if you undergo any of these weight loss surgeries. And for patients who undergo any sort of rapid weight loss, they will notice some thinning of the hair. The faster you lose your hair, the more noticeable that hair loss is. But this hair loss is not permanent. It's just temporary. And usually it lasts for about 6 months. And then once your weight loss slows, your hair will grow back to where it was before. The last thing is excess skin or cosmetic surgery afterwards. We do recommend that you wait until your weight loss has stabilized or you reach your baseline weight before pursuing any type of cosmetic surgery such as tummy tucks or removing the excess skin on your arms or on your thighs. Because you don't want to have cosmetic surgery done, then lose additional weight and have loose skin again in the same area. You want to have the surgery done once you've reached your baseline weight. Unfortunately, most insurances don't cover these cosmetic procedures. Some of them will cover, the tummy tuck if you do have any sort of medically associated problems with this excess skin, abdominal pain, back pain, chronic rashes, skin fold irritation. These are things that if you do have them, make sure you let your primary care physician know. Make sure you let us know. That way it will be documented and chart so you can have the surgery done if the insurances will cover them. Most important thing to remember is that obesity is a complex disease. It's a chronic disease. It's not something that you can just take a pill for or even just have a surgery for and get permanent long-term results. Even the most perfect surgery that we do may not get patients to lose as much weight as expected, or patients may gain weight back in the future. Really, the key here is to teach patients how to eat differently in the future. Smaller amounts, eating slowly, to actually savor every bit of food that you're eating. I mean, the real reason why you cook your food is to flavor the food so it's enjoyable to eat. And we try to get patients to get away from eating so much and so quickly that they feel like they get that bloated sensation after Thanksgiving. That's not really the purpose for eating.
Now, Dr. Fang will go into more detail about the surgical procedure itself.
A lot of patients have preconceived notions as far as which operation they want to undergo. But each one's different. There are advantages and disadvantages of each type. And we look at what patients' expectations are as far as how much weight you're looking to lose, some of the things that you're concerned about as far as side effects of each operation, and also any particular medical conditions which may be treated better by one operation as opposed to any other operation for weight loss. We do about 95% of our abdominal surgeries laparoscopically. That means the operations where we use the little incisions rather than the large incisions. The advantage of doing the surgeries laparoscopically isn't just the obvious reasons where you've got smaller incisions and therefore less scarring, less pain, more rapid return to normal activities, more rapid return to work, but also the risk of wound infections is 10 times less with the laparoscopic approach, and the chance of incisional hernias from the laparoscopic approach is much, much less. It's about 1% as compared to probably 30 to 40% with open surgery where you have a large 6 to 12 inch long incision. We try to do all these surgeries laparoscopically if we can. The times that we can't do these surgeries laparoscopically are usually if there's extreme or excessive weight in the patient's abdomen, or there's too much scarring or anatomic distortion from previous surgeries. Most times we plan to do the surgeries laparoscopically, and if there's a chance that we have to convert it to an open surgery, that's about 2% of the time.
Dr. Fang will now discuss the medical health insurance considerations.
As far as insurances go, most insurances require not only a specific weight for qualification for weight loss surgery, but they also require some form of medically supervised weight management. And this may be a diet that's documented by our primary care physician or any weight loss clinic. And most insurances do require a period of time that varies between 8 weeks to as long as 12 months, depending on what insurance plan that you have. For patients who start in this program here, you'll be assigned a bariatric advocate who will help you maneuver through these requirements to let you know exactly what your insurance will require to qualify for these surgeries. Patients really need to understand what you're getting into here. Need to understand the different types of surgeries that are available, and also the specific lifestyle changes and eating changes that are necessary for each of these operations to be successful, and also to maintain this weight loss permanently.
Lastly, Dr. Fang will tell you about the Bridges Center accolades and what makes our bariatric program a recognized center of excellence.
The Bridges program has been certified as a center of excellence for weight management, and what this means is that an independent corporation has actually come in to survey this site to look at our results, our complication rates, and also to look at the actual facility itself to make sure that the furniture, the operating room table, the instruments that we use are sufficient to handle treatment for a patient who's much heavier than the average patient. The nurses on our bariatric floors also get additional training as far as taking care of the bariatric patients. And we also require a psychological evaluation for all patients. The reason for a psychological evaluation isn't just to determine if patients have any psychiatric or psychological problems that need to be taken care of or addressed prior to surgery, but also to be sure that patients are prepared for the pretty significant behavioral, eating, and other changes after the surgery itself.
Now that we've talked a little bit about the different procedures, let's talk about a few things that we want you to do to get ready for surgery. We want you to gradually reduce the amount of caffeine that you consume and start to work on drinking 64 ounces of water throughout the day. It's a good idea to stop drinking carbonated beverages now before surgery. You'll not be able to drink carbonated beverages or sparkling water beverages after surgery. We also want to start to reduce the amount of high sugar and processed foods in your diet to prepare you for a long-term healthy plan. It's important that you stop smoking as you prepare for surgery. So speak with your surgeon, your advocate team, and your primary care doctor to make sure that you've received all the resources you need so you can quit smoking today. We require that you be nicotine product free 6 weeks before surgery. As we look through your experience from surgery through 5 years out, a lot of this information is going to be presented to you in your 101 and 201 education classes. We'll review what to expect in the hospital, what will happen in admitting and pre-op, and we'll prepare you for the operating room, as well as talk to you about your post-surgery recovery, your responsibilities while you're a patient on the floor, and your long-term follow-up plan. Follow-up is very important. It helps you maintain your success. So we encourage you to come to your monthly support group and educational class as schedule permits. In getting ready for surgery, your very first step is attending this webinar. Following the webinar, we'll check your insurance benefits, make sure that you have the referrals and authorizations you need so you can begin your weight loss process. A very important step is your surgery consultation with the surgeon. This is when you'll meet individually with your bariatric surgeon to discuss what surgery is the best fit for you. You'll start to gather some standard medical records and supporting information, and of course, we want you to attend the 101 and 201 classes as you progress through the approval process. Obtaining insurance information authorizations can be challenging. Be prepared that it may take 3 to 12 months to complete this process. Your patient advocate will provide support and assistance along the journey. So feel free to call us anytime if you have questions. Some standards required from each insurance company will include a letter of medical necessity or a letter of support from one of your primary care doctors. You will be required to have a psychological evaluation where you'll meet with a bariatric psychologist. The psychologist will review with you all the changes that occur in surgery and make sure that you are prepared for long-term success. You'll document all the diets you've tried in the past on your health history form. We'll verify attendance today as well as your attendance to the 101 and 201 classes. As you meet with your surgeon, they'll determine if you need a cardiac clearance or a pulmonary clearance. Some possible reasons for these may be required that you are over the age of 50 or that your body mass index is over 50. Some insurance companies may require medical records documenting your weight history for a period of 1 to 5 years. You may be required to do a diet consult, a medically supervised diet, and an exercise program, or you may be required to do some additional tests, like an A1C or an H. pylori bacteria test. The first step in working with your insurance company is to see if you need a referral from your primary care doctor before meeting with one of our surgeons. Your patient advocate can help you locate this information on your insurance card. Just to remind you, the surgeons are here to help you determine what surgery is the best for you for a healthy and permanent weight loss. We're here to help you manage your insurance requirements. We're here to help you get ready for surgery and education and support. And we're here to help you as you get closer to surgery with education and recovery. We're also asking you to be committed to a 5-year follow-up program to keep you successful long term. What's next? After completing this webinar, you will be instructed to take a quiz. Please complete this quiz. Within 48 hours, a patient advocate from the Bridges Center will be calling you to review your insurance and to answer any additional questions you may have. Please review the health history form, the demos and consents, and the other documents that are available online. Once your insurance has been verified, the next step is to schedule a consultation with our surgeons. You'll work with your patient advocate regarding your insurance requirements and medical clearances needed for surgical approval. You'll attend your 101 and 201 education classes. You'll be asked to complete a high-protein liquid preoperative diet 2 weeks before surgery. Once your surgery is approved, the surgeon's office will call you to set up a preoperative testing appointment scheduled about 2 weeks before surgery. Congratulations! You've just completed an important step in your journey to weight loss surgery. If you have any questions, call us. The Bridges team is here to help. We can be reached at 1-800-248-5553. So we look forward to being part of your weight loss journey. I'd like to introduce you to Alicia. She's one of our many success stories.
This is the old me, and I don't know who she is, but I know who I am now. My name's Alicia, and 5 years ago I decided to change my life by losing weight. I never realized how heavy I was until I lost the weight and figured out who I was up under all of that weight that I had. I never imagined what life would be like being skinny. I didn't even know what skinny was because I carried around all my weight for so many years. But once I lost all my weight, I found the new person that I didn't even know was hiding up under there. So with having my weight loss surgery, I'm able to run with my kids, play with my grandkids, and just enjoy life overall. For me, losing weight naturally did not work. I was like on a yo-yo diet. I would go up and I would go down. So I'd lose 10 or 15 pounds. And if I lost 10 or 15 pounds, I gained an extra 5 more pounds. But with having the weight loss surgery, I haven't gained back anything. Nothing at all. I've kept it off and I continue to lose weight. I'm no longer sad. I'm no longer what I guess you would say depressed, because I no longer carry that extra weight around, and that extra weight gave me no confidence. Now my confidence level is it's way up there. I'm happy. I get compliments all day, every day. And when I tell people I had weight loss surgery, they would have never known that I used to carry around the 80 pounds that I used to carry around. And they look at me and say, wow, you look great. And here I am. My life is transformed. This is the new me.
It's your day.